This is Dr. Christopher Sendy of Nova Health Recovery Ketamine Infusion Center in Alexandria, Virginia. And I'm going to discuss ketamine therapy and how ketamine works so rapidly in treatment-resistant depression. Now, we do know ketamine is a rapid-acting antidepressant, and it effectively treats 50 to 75% of treatment-resistant depression patients who will have significant response, if not remission, with a series of ketamine infusions, generally 6 infusions over 2 to 3 weeks. And effects can be noticed within hours, but generally by the third or fourth infusion, the majority of patients who are going to respond will start to have a response. Now, these responses can last several days to a few weeks in most, but some will have prolonged remission. And periodic booster infusions or even home microdosing can maintain the efficacy. But these are individuals who have failed multiple other antidepressants, multiple other treatments, TMS, transcranial magnet stimulation, and even ECT. So these individuals have been challenged through a really difficult mental health journey. Now, depression is neurodegenerative and it's progressive. And we know that all available therapies that we utilize continue to have the need for tune-ups or boosters. In fact, traditional antidepressants are taken chronically. Patients who are started on Prozac generally stay on antidepressants over the years to prevent relapse and to maintain remission. And even transcranial magnet stimulation requires periodic boosters. We know that the STAR-D trial demonstrated abundant failure of traditional therapies in depression. In fact, only 1/3 of patients who are treated with an antidepressant will actually get remission with the initial therapy over that 2 months. And of those that responded and had remission, half of them relapsed within the year. And the other issue is tachyphylaxis, that individuals on antidepressants will slowly need higher and higher doses of antidepressants in order to maintain the effect. Now, we know even psilocybin therapy requires maintenance. And in this particular study with Carhart-Harris, basically psilocybin demonstrated significant impact on depression and mood. But of 19 subjects, 6 restarted an antidepressant after 6 months, and 5 needed a psychotherapy, and 5 took off-label psilocybin for additional dosing. And 30% of week 5 responders relapsed at 6 months. So it really doesn't matter where the treatment came from. Basically, depression and mood disorders are relapsing and remitting and require continued therapy. There's no cure. And so when we look at the STAR-D trial and the response rates, traditional antidepressants work slowly if they work at all. And we know from the STAR-D trial, which basically just kind of walk through the slow efficacy of traditional antidepressants and the failures as well, that basically antidepressants frequently take a long time to work when they do. And for those that do have effect, a lot of times those effects go away and they will relapse. And so we know that depression is poorly controlled in over 67% of antidepressant treated patients at 12 weeks. And we see in this graph from the STAR-D trial again that 33% got remission in those 12 weeks, but the other 67% had variable degrees of mood symptoms. And of course, this impacts quality of life and other parameters in the person and their ability to function, and also the way that they feel. So the traditional therapies just don't seem to work that well. And they are based off of monoamine type systems, serotonin and dopamine. And we know that more recently, especially, there was a systematic review which was in Molecular Psychiatry, Nature magazine, in July of 2022, which basically did a systematic umbrella review of the evidence of the serotonin theory of depression. And effectively, they found no evidence of there being an association between serotonin and depression, and no support that, of the hypothesis that depression is caused by lowered serotonin activity or concentrations. And that actually antidepressant use actually lowers serotonin concentration. So depression isn't really a chemical imbalance. And more recently, there were in the lay press discussions of this very fact, or if you want to call it a fact, this systematic review, basically just readdressing the fact that um, there's a lot of controversy over whether or not serotonin and dopamine are the cause of depression or whether they are just the end product of other factors that result in depression. And reality is that, yes, something else is producing depression, and they're basically shaping the tone of serotonin and dopamine. And what really is believed is that the glutamate system may be the driving force in mood and learning. And glutamate is the most excitatory neurotransmitter in the brain. It's a amino acid actually that we can produce from the Krebs cycle. And glutamate can be actually synthesized from a number of amino acids, but it's actually a molecule of learning, and it composes close to 60% of the neurotransmitter load in the brain, in the human cortex, and any mammalian cortex is run by glutamate. And so if there's learning involved, glutamate is present. And glutamate actually produces GABA. And GABA, as we know, which is gamma aminobutyric acid, is an inhibitory amino acid in the cortex. And so glutamate balances itself out with GABA. And so just as a general discussion for those who aren't aware, synapses are basically composed of two neurons and actually even more components, which we'll show, because astrocytes and supporting cells actually are part of the synaptic cleft. But we have a presynaptic terminal, which you can see here at the top, and that's where the signal comes from. And then these little vesicles fuse, and they contain the neurotransmitters, such as glutamate, which then exits and interacts with receptors, such as the NMDA receptor or the AMPA receptor. And then at the postsynaptic terminal, a signal is resulting from this. And what happens is these receptors, as seen on the right side, actually open up, and they're channels, and they allow sodium and even calcium to flow in, which depolarizes the postsynaptic terminal, and that's where the signal goes to. And it's important to know this because when we talk about neuroplasticity, when we talk about depression and neurocircuitry, synapses are involved. That's basically neurons where they connect, and where these neurons connect, basically dendritic spines are important in the formation of these synapses. So on the right-hand side here, we see a presynaptic neuron where the signal comes from, and it spreads through the synapse and the synaptic cleft to the postsynaptic neuron. And we know that there are basically dendritic spines on the postsynaptic neuron, and these dendritic spines are little outpouchings of growth that basically are able to connect with other neurons to create new synapses where new learning can occur and new information can be spread. So these little fuzzy outcroppings here on these postsynaptic areas basically are dendrites, and they're important because dendritic spines basically disappear in times of stress and medical illness. So stress leads to a loss of dendritic spines and synapses. So here is a postsynaptic neuron, and there's little dendritic spines here. And as stress occurs for various reasons, we see the loss of these spines. And so there's fewer and fewer of them. So there's fewer ability to have connections. And so stress causes neuronal atrophy. It causes loss of dendrites. And it's due in part to excess amounts of extrasynaptic glutamate. And glutamate's necessary to be around for learning and to operate our cortex, but if it's around too much, it causes damage to our brain and causes dendritic spine density to decrease. And so we generally want to, of course, avoid stress, but with chronic stress, we get dendritic spine retraction. We get reduced dendritic arborization and spine density. You can see the difference between a non-stressed neuron and a stressed neuron. And these particular pouches, which again are involved with the formation of new synapses, disappear. So fewer dendrites, fewer spines result in a stressed retracted neuron. And so it continues on from there that signaling begins to fail because there's fewer connections and even fewer neurons after a period of time. And of course, with dendritic spines and synapse formation, that's involved with learning, it's involved with cognition. And so as a result of the loss of these connections, we start to lose cognitive abilities. So what happens after synapses fall apart? Well, there's a cascading effect of neurodegeneration from synaptic loss. So there's actually atrophy in key areas of the brain involved with everything from decision making to impulse control and memory. We see brain fog, we see poor decision making, poor executive functioning, irritability, and insomnia. We also can see on the MRI of individuals who are depressed that there's actually shrinkage in key areas of the brain, like the hippocampus and the prefrontal cortex, and which is the CEO of your brain, involved with executive functioning, and other key areas involved with reward and also working memory and emotional memory. And this results in neurocircuitry functioning changes. So basically, the circuits get messed up. And this results in problems with motivation and reward and delayed discounting. And delayed discounting is the ability to see the value in doing something now for later on. So, for example, taking ocular vitamins. I don't see better the next day when I take them, but I'll see better in 20 years. So I take them because I know better. Or brushing my teeth. And so when I brush my teeth, I'll save my teeth to eat a steak for 5 years from now because they're not rotten out. And so when individuals get depressed, they lose the ability to have delayed discounting. They only want to do rewarded activities right now. If it doesn't reward them, they're not going to do it. And that's why it's hard to get out of bed. It's why it's hard to brush your hair or take a shower when you're really depressed, because delayed discounting just doesn't work. And we also start to get cognitive distortions and fixed cognitive beliefs. And these include things like negative social biases, that everybody hates me, nobody likes me. And then also general fatigue also sets in because of changes in brain bioenergetics. And then there could be also inappropriate activation of something called the default mode network. And this results also in problems with attention and concentration. The default mode network is a self-referential network. It is a network that functions when we're not really doing anything or focused on a task. And the problem is that the default mode network over-activates when we're depressed. And it starts to actually interfere when we're doing tasks, so that if I'm busy doing a specific task, like working on a problem, and all of a sudden I will just start to daydream or start to think of negative things. And that interferes with my ability to work, almost like as if I had ADHD. But the reality is that I have two networks fighting with each other and competing. And then also we see increased brain aging due to basically changes in sirtuins. And then also cognitive scarring. There's actually a loss of verbal memory even in between depressive episodes. And there's even changes in visual spatial processing. And there's medical complications such as heart attack and stroke and diabetes due to insulin cycling changes. And so people who are depressed or have mood disorders will actually die 10 to 15 years earlier potentially because of medical complications, not because of suicide or something awful like that, but rather heart attacks. And so there are a number of systems that control our cognitive function, and cognition is really important in depression because it's one of the first things that goes when an individual starts to lose mood, when they start to get depressed. And we have a couple of different networks, one which is, for example, the salience network, involving the salience of event. It identifies events that are non-automatic responses, so things that require us to kind of focus on them. And then we also have the central executive network and a default mode network. And these networks can't all be operating at the same time. And each of these the networks is basically driven by different areas of the brain. And when a person gets depressed, we start to see the default mode network, basically the daydreaming network and the self-referential network, the autobiographical network, so it is, starts to function in a larger degree than it should, so that it interferes with our ability to evaluate tasks in a salient fashion, or to even focus on getting tasks done. And so this actually prevents us from doing our job. It prevents us from basically allowing our cognition to multitask and get our work done. And so we see people fail at work because of their cognitive loss due to depression. And as a result, also people start to basically make poor decisions and have poor insight over things. And so again, these cognitive areas, and again, we kind of just outlined here the central executive network, the salience network, the default mode network, operate in different areas of our brain. And these are just kind of grossly drawn on this particular screen. But what's important is that, again, the default mode network, GAN is although useful, operates in the wrong time when patients are depressed, and this can lead to a lot of negative consequences. And so when we look at patients who have mood disorders and depressed, there's issues with memory. They get forgetful, poor short-term memory, difficulty with calculations. And then there's problem with slowing of their psychomotor speed. So they just feel like they're moving in slow motion, and they feel tired and lethargic, with poor focus and attention and low concentration, hard to listen. And executive functioning, they just can't carry out their plans. They have difficulty synthesizing information and making a decision, if they make decisions at all. And they have lack of confidence or indecision, and difficulty with multitasking, which affects them at work. And so that's why people lose their job. They lose financial ability, and they lose their families. And we know that depression is basically, and mood disorders is a cognitively scarring disorder. In this particular study by Gorwood in 2008, there was a 2% decline in verbal recall per episode of depression. And even between episodes of depression, there appeared to be verbal memory loss. So there is clearly cognitive loss going on even in between poorly treated episodes of depression. And we also know the amygdala fires off excessively in depression, as well as the lateral habenula areas involved with negativity and stress and fear. And the amygdala in particular connects to so many areas, in particular the central autonomic network, and it integrates autonomic responses, so that we breathe faster and sweat and our heart rate goes up. And of course, this affects our sympathetic tone, it affects our cortisol levels, and also it affects the DMN, which again is that self-referential network that we were just speaking of, the default mode network. And so we can discuss various aspects of cognition. Certainly something else another video would have to discuss entirely, but there are actually a number of circuits involved with our ability to look at things around us and the way that we perceive the world, in particular hot cognition, which represents areas of more emotional tone. And we see individuals who are depressed have more negative biases. They think more negatively of the world around them. And when they look at a neutral face, they think of that person as being angry at them or mean or sad. And there's decreased regulation of behaviors. In other words, the top-down control is less. So individuals are more likely to be impulsive or get angry or irritable or lash out. And mood is lower too. And that's because as a person gets depressed, these limbic areas, these red spots here, the amygdala, insula, orbitofrontal cortex, and anterior cingulate in the ventral section in particular, begin to overreact in depression. And they tend to pick up more on negative emotional cues, and they overreact as a result of that. Whereas when we're not depressed, the areas in the upper brain, like hippocampus, dorsolateral prefrontal cortex, dorsomedial prefrontal cortex, should be in control. And so we begin to think more with our lizard brain as we get more depressed. And this is really problematic because when you have hot cognitive deficits, you begin to be more effectively labile. And individuals who are depressed tend to have greater responses to negative feedback. So if you give them a little bit of negativity, they're going to just take it to the next level. And this can impair their performance on what we call cold cognitive tasks, like 100 minus 7 is 93. The ability to think through that begins to be affected by a person's emotional tone. And so people begin to be more and more negative whenever they're more depressed. And so it gives a negative focus on our attention and perception and memory. We'll always focus on negativity when there's plenty of positivity around us. So we're less like SpongeBob and more like Squidward as we get depressed. So the real question comes if serotonin and dopamine, the lizard brain molecules, aren't in control of our mood and depression, then what is? The work on this started in the late 90s, and even as early as the early 70s, with the recognition that glutamate has a key role in mood disorders and depression. And we see that there were numerous studies demonstrating that glutamate had an effect on learning and mood and cognition, and that aberrant signaling of glutamate actually might be a significant cause of neuropsychiatric diseases. And so glutamate is the master neurotransmitter in some ways, mainly because of its significant abundance. And it also is what really runs the cerebral cortex, which is present in mammals. And so we mentioned earlier that the synapse isn't just about neurons, but also about the supporting cells, the astrocyte, which is not technically a neuron, but is involved with glutamate cycling. And glutamate cycling, which is very important because glutamate is our neurotransmitter of learning, and it's a neuroexcitotoxic type of a neurotransmitter that should only be around for just short periods of time. But in presynaptic neurons, glutamate is basically spit out into the synapse, and then it's allowed to interact with the postsynaptic neuron. But the role of the astrocyte is to do a couple of things. One is to suck up that extra glutamate and then put it back into the system again so that the presynaptic neuron can be effective. But also the astrocyte can also spit out a low dose of glutamate just to keep a little bit of tone so that there is actually a certain amount of tone in the synapse as far as that there's some low level signaling. And so we are beginning to find that depression and mood disorders aren't just about neurons, but actually the astrocyte itself may play a significant role in basically the progression of depression and mood disorders. Now, what are we going to do about this? Well, ketamine has been found to affect glutamate cycling, and it rapidly alters depression through rapid neuroplasticity. We know that when individuals, in particular, like for example, mice, when they're studied, and if they're not stressed, we see that a neuron may have a normal number of dendrites, but when stress occurs, there are fewer and fewer dendrites. And it has been found that the treatment of these mice with ketamine rapidly results in the progression and formation of new dendritic spines. And this allows for new neuronal connections and rapid antidepressant effects. And when it comes to what else that psychedelics and things like ketamine may do, we know that a lot of times that individuals who are depressed are very cognitively rigid. They can't think outside the box. It's either A or B, but nothing in between. And the problem with that is it decreases resilience, it decreases adaptability and flexibility. So we can only think in certain ways. And we see this in individuals who are cognitively stuck. So basically, the less flexible your mind becomes, the more affected it can be made to outside forces, and you can become depressed. And we see in psychedelics that when an individual is given no psychedelics, that there's signaling between key areas of the brain that generally, if you look at the colors, they generally match up with each other. So we don't generally notice, like for example, our sense of smell communicating with our vision, and maybe our hearing communicating with our taste. But if you give an individual a psychedelic, psilocybin or whatever it might be, or even ketamine, there's actually increased crosstalk in key areas of the brain. And this basically gives the experience of the trip itself in part, but also allows the exchange of information and also kind of shakes up that cognitive rigidity so that the individual can start thinking outside the box and seeing new opportunities for learning, and maybe take a look inward to see that maybe the encapsulated beliefs that they've accumulated that they generally default to, even if they're horrible, like depression and negativity, even though that they are used to being in that state, that maybe that there are new opportunities for their brain to grow and learn and consider new adaptable tasks so that they feel better. Now, the actual way that ketamine works and how it makes things basically happen as far as neuroplasticity is fairly complex, and they're still learning a fair amount about it, but it's not like we don't know anything about ketamine. And we're going to go through this here with a couple of slides. And basically, you can see two synapses here. On the left side, we have a presynapse and a postsynapse. And we have this GABA interneuron. And these are neurons in the cortex of our brain. And we know that whenever ketamine basically shuts off this GABA interneuron, that by turning this off, it actually turns on this synapse. So this GABA interneuron is basically like the off switch for the neuron. And by turning the off switch off, it allows this neuron to basically have a glutamate burst. And these are the glutamate molecules right here, and they interact with AMPA receptors on the postsynaptic synapse here, on the postsynaptic neuron. And then this results in basically the formation of proteins. And this is where neuroplasticity comes from. And so we'll just kind of go through this step by step. So in this particular case, we have a presynaptic neuron at the top. We have the GABA interneuron, which is turning off this entire system. So this is the off switch right here, the GABA interneuron. And this is the postsynaptic neuron, this giant area here, just for display purposes. And we have an AMPA receptor here. We have an NMDA receptor there, and ketamine is an antagonist to this. It turns it off. And then we have the AMPA receptor, which is also a glutamate-driven receptor, as is NMDA. And the first thing that we notice also that there's in the postsynaptic cell, we have things like mTOR and brain-derived neurotrophic factor vesicles. And when we basically give a person ketamine, ketamine binds to the NMDA receptor here on this GABA interneuron, and it then causes this presynaptic neuron to actually create a glutamate burst. It allows the glutamate that's in these little vesicles to actually fuse with the surface, and then it causes them to emit out. So step 2 is the glutamate burst comes out of this presynaptic neuron and interacts with the AMPA receptor right here. And by doing so, the glutamate then allows sodium to enter into this cell right here, the postsynaptic neuron, and it depolarizes it. And so that follows up with the next step, which is basically by depolarizing this, it allows the vesicles with brain-derived neurotrophic factor to fuse, release, and interact with TRKB, which is tyrosine kinase beta. And this then allows other proteins to get activated in the postsynaptic neuron to then activate mTOR. And mTOR, as we all know, is involved with the formation of proteins. And the proteins in particular are, for example, PSD95, and it's postsynaptic density 95, and GluR1, which basically allow the formation of protein scaffolding and dendrite formation. So by just them inserting into the membranes and doing their thing, it allows for basically scaffolds to form and new synapses to form through dendrite formation. So it's a very complex thing here, and there's still a lot more being learned from this, because there's also downwind effects of this, which includes that this ultimately can turn on serotonin and dopamine signaling. And there's also questions of whether opiate receptors are involved as well as a number of other receptors. But the primary focus here, and what we know to be a key regulator of neuroplasticity, is what goes on in the cortex through this whole system that's driven by mTOR, ultimately the production of proteins. So what does this synaptic growth result in? Well, it results in rapid improvements in multiple domains. It results in mood elevation. Days after the ketamine is out of the system, we still have mood elevation. So within an hour after you get your ketamine infusion, ketamine is basically causing the production of these proteins, and it allows that glutamate burst, and then the ketamine goes away. So an hour later, there's no more ketamine in your system. So if you're feeling better several hours later, it's because of basically dendrite formation. And also the ketamine itself causes the amygdala and lateral lobennula to kind of dampen down, just to kind of quiet down, so that you don't have all that negative feeling, the negative thoughts and ruminations. This also allows for improved cognition, because you're improving neuroplasticity and synaptogenesis, and that repairs neural circuits that have been damaged. But just remember, it repairs those circuits. And the circuits are slightly different, because where these dendrites form and the connections form, they are different, and they need to be basically maintained as well. And we'll discuss that later. But ketamine doesn't change your personality. It doesn't make you like things you generally don't like. It basically is just involved with repairing the circuits that have been damaged already. And the effect of ketamine on somebody who's depressed versus not depressed are two totally different things. So they have two totally different experiences, and the outcomes are different. But one thing is noted is that there are fewer negative thoughts, less anxiety, less ruminations, less self-sabotaging behavior, and better self-esteem overall in individuals who get this type of neuroplastic repair. And we notice increased motivation, increased concentration and focus, as well as less fatigue. So all the things that traditional antidepressants don't deal with, ketamine does actually make better. And also ketamine treats anhedonia, which is lack of mood at all. And traditional antidepressants frequently cause emotional blunting, which is no excitement in life and the next great adventure. In fact, a study here by Sharoma demonstrated that 6 ketamine infusions actually increased wellness indicators that no antidepressants really have been evaluated or been shown to actually improve. So ketamine infusions improve calmness and energy and happiness, and they make you less worried, less sad, less tired, and feeling less worthless. And this is all based on 6 ketamine infusions at 0.5 milligrams per kilogram over 40 minutes, Monday, Wednesday, Friday type scheduling, which is what we do at Nova Health. So ketamine basically works in a rapid antidepressant fashion through a quick glutamate burst, and that glutamate burst ultimately results in the production of proteins. Those proteins cause dendrite formation, new synapses, and also neuroplasticity. It repairs neural circuits throughout the brain. It allows for individuals to have their circuitry work better so that their attention, focus, and concentration are better. It also allows the individual's cognition to come back online. Ketamine also improves the functioning of the default mode network. It actually turns that default mode network off so that it's not interfering with your task focus network. It actually allows you to focus on what you're doing as if you're on Adderall or something, and keeps that default mode network at bay so that you can do the things that you need to do. And likewise, ketamine turns off the negative side of your brain so that you don't have the ruminations and the negativity and the anxiety and the low self-esteem. And it also improves motivation as well. And this is seen in between 55 to 75% of patients. It is a treatment, not a cure. The goal is to get the person into remission so that they don't need to be treated as frequently. But generally, effects can be seen within hours to a few days. And the maintenance and the results can last for several days to several weeks, even up to several months or even longer for some individuals. But it does work well. Ketamine does work well with your traditional antidepressants, and it can be used to kind of start your new antidepressant up so that it's made more effective faster. And so ketamine is finding a huge role, as are other psychedelics, in the treatment of depression, mood disorders, and a number of other conditions that intersect with mood, pain, and a number of other phenomena that occur in the brain.